Welcome to our second chapter of this complete CLL course that the UK CLL Forum is doing in collaboration with CLL Support. Would like to start with big thanks to the CLL Support team and to our hosts, George Fellows and Renata Walewska.
So thanks for the kind introduction from Nick, our UK CLL Forum chair. As we've discovered already that Nikesh is back from illness to join our panel. He couldn't join us last week, so we have a Nick and a Nick. So we're going to have a Nikesh and a Nicholas in our panel chat. The meeting we've put together this evening is very exciting. We're starting off with some pure sort of data-driven approach, how we manage first-line CLL, which is going to be delivered by our good colleague Helen Marr, who's a consultant haematologist up in Newcastle. The second session, which Renata will be chairing, is taking a more patient-focused view. John and Peter are joining us from a patient perspective, so we're really excited about what's going on. And remember last week, great questions coming in from the UK audience. It really does add to our discussion. And the feedback we're getting is very consistent that the discussion works really well. So again, to our speakers, don't worry if you finish your slides early. We can chat about CLL all night. As we just said in January, what else would you be doing on a Monday evening, apart from sitting in talking about CLL? So thank you, Nick, for the introductions. Helen, should we hand over to you to kick us off?
Right, thank you so much, George. So I'm Helen Marr, and I'm a consultant from the Freeman in Newcastle, or the Toon, as we call it up here, and I'm going to be speaking about treatment-naive CLL. These are my disclosures, and I'm going to try and keep things fairly practical. So I'm going to talk about when to treat, a quick thing on something, what not to miss when you're thinking about treating a patient, what our treatment options are currently, and then the main bit of the talk will be how to choose which treatment for which patient. And then something about managing the treatment, so side effects, logistics, and things to remember when you're treating patients. So I'll start with when to treat. And we have some very clear guidance in terms of the IWCLL criteria for when to start treatment in a CLL patient. And you can see it's mainly focused around things to do with cytopenias in terms of bone marrow infiltration, bulk of disease, splenomegaly or lymphadenopathy, autoimmune complications which aren't responsive to steroids, and then also sort of disease-related symptoms. I'm just going to make a few mentions of a couple of things to do with each of these. So the first thing, if your indication for treatment is related to cytopenias, specifically anemia or thrombocytopenia, just be really clear. Don't make any assumptions in CLL. Be sure that the cytopenias are definitely due to CLL bone marrow infiltration and nothing else, first of all. So check hematinics, B12 folate ferritin, do a hemolysis screen. I would kind of consider those the first, essential things to do before you assume that your anemia is due to bone marrow infiltration due to CLL. Particularly if the patient has an isolated thrombocytopenia or an isolated anemia, just think, could this be autoimmune? So make sure you've done your hemolysis screen and even consider whether a bone marrow is needed. So I do bone marrow biopsies very infrequently really in CLL, because mainly we can make the diagnosis from blood, or maybe the diagnosis has already been made from a lymph node biopsy. And it's quite infrequent that I do a bone marrow. But I guess the time when I might do one is when I'm wondering about starting treatment and I want to be sure that I'm treating the right thing. So if, for example, the cytopenia has progressed more and out of keeping with a change in the lymphocytosis or a change in the nodes, I would want to be certain that the cytopenias are due to the CLL rather than something else. Note that autoimmune anemias or thrombocytopenias in themselves are not a criteria for starting CLL treatment, but if they're not responsive to first-line treatment, for example, with steroids, then you can go along and treat CLL as the underlying cause. And then something about disease-related symptoms. I think this is one of the hardest ones. If you have a patient who doesn't fulfill any of the other criteria, 1 to 6 on this list, but they're presenting with a lot of symptoms, particularly fatigue, I think is really difficult, because we know that fatigue and other symptoms can be caused by all manner of things. So it's just being very clear with the patient and exploring other reasons or causes for symptoms before jumping and assuming it's due to the CLL. Now, you've decided to treat your patient. This is my quick what not to miss. And this is just always think about Richter's so that you don't miss it. So if you're about to start treating a patient for CLL, just think, could this possibly be Richter's? And the vast majority of times it won't be, but you have to have a clinical suspicion of it to make the diagnosis, else you will miss it. So if your CLL patient has asymmetrical lymphadenopathy, so 1 or 2 nodal sites that have grown out of proportion with everything else on their scan, or if they have very prominent B symptoms, weight loss, fevers, drenching sweats, a high LDH, or if their change in symptoms or progression of their disease has occurred very rapidly, then just think, could this be Richter's? And if you've started to have that thought, then do a PET scan. PET scans can be helpful if there's one particular area that is bigger or more FDG avid, and a cutoff of SUV max of around 10 can be helpful in terms of being quite sensitive and specific for a high-grade transformation. So if you've had a clinical suspicion, do a PET, and definitely do a biopsy if on your PET you're seeing one area or a couple of areas that seem out of keeping with the rest of the disease with a high SUV max. But there'll be much more on Richter's next week. So treatment options currently. Well, we can summarize our treatment options right now in January 2026 as being one of or a combination of Bruton tyrosine kinase inhibitors, so BTKIs. Now, typically people would now tend to use the covalent second generation BTKIs, acalabrutinib or zanubrutinib. We do still have access to ibrutinib, which is one of the first generation BTKIs, but because of toxicity profile, the majority of people now would tend to use a second generation instead. In terms of BCL2 inhibitors, so the only one we have currently available to us is venetoclax, and then anti-CD20 monoclonal antibody. In the frontline setting, we would use obinutuzumab. And note that we only have access in CLL to obinutuzumab in treatment-naive patients. If you're treating CLL in second or later lines of treatment, then we use rituximab. Just a note that chemoimmunotherapy is no longer recommended in treatment-naive CLL. So what do we currently have licensed and funded? And I've underlined January because later on this year, things may change again. But in previously untreated patients, we have this distinct split between either fixed duration and continuous treatment. And we're going to talk about that a lot as this talk goes on, and I'm sure in the discussion section. So when we're talking about fixed duration treatments, they are always venetoclax based in this setting. So either venetoclax and obinutuzumab, which is given for 12 months in total, or ibrutinib and venetoclax, which is given for 15 months in total. So there are two fixed duration options. Or we can give a continuous treatment, which is with a BTKI, given as a monotherapy. And here, as I say, most people use acalabrutinib or zanubrutinib rather than ibrutinib. We do have access to a continuous venetoclax monotherapy. I think this is probably fairly rarely used, but we would tend to use that if for some reason we didn't want to deliver fixed duration or we were unable to give a certain patient obinutuzumab in somebody who is also unable to receive a BTKI. Idelalisib and rituximab we also have access to, but I think very few people would use that now in light of the other treatment options we have available to us. I said that we might get changes as the year goes on. Fixed duration acalabrutinib and venetoclax in combination may become available to us later this year, but we wait to see the outcome from NICE. So how to choose which treatment for which patient, and this is going to be the bit of the talk which takes the longest, so we'll go through some of the data. First of all, when we're thinking about how to choose which treatment, we've obviously got a number of factors to take into account. Factors from the point of view of the patient, so comorbidities, other medications, and really I think there we're focusing on renal or cardiac history and particularly anticoagulation or antiplatelets. And we'll come back to these patient factors a bit later in the talk. Disease factors, and Dima's talked to you last week about some of the disease factors that we know can have a prognostic impact on patients, particularly in terms of either a DEL17P or P53 mutation and IGHV status. Disease bulk, I've put a question mark. There's maybe some data that says that we should take that into account. And the speed with which the disease needs to be controlled, and we can mention that a bit later. And then patient factors, and some of those will be very specific to the patient. I'm always amazed, patients can be absolutely dichotomous. Some patients say, I would rather be on a continuous treatment, it feels reassuring to me. And other patients say, absolutely not, I want to be on a treatment that comes to an end so I can then get on with my life and forget about this. So patients are just completely different, and you need to obviously talk to them about what their options are and what their preference would be. So all of the options that we saw on the last slide are on the table, and no treatment choice is wrong. I'm going to just mention something specifically about fixed duration versus continuous, which I think we should have in our minds and should talk to patients about specifically. Many people would consider that one of the main benefits of a fixed duration treatment is that the patient gets a treatment-free period. So they have their treatment over either 12 to 15 months, depending on whether it's Veno or IV treatment, and then that treatment will come to an end. So for as long as they remain progression-free, not needing any further treatment, they are off treatment and they get a treatment-free period. And therefore, the exposure to the toxicity of the treatments they're getting is time-limited. Compared to continuous treatment, where the patient, once they start the continuous BTKI monotherapy, they will stay on it until either they have to stop it because of toxicity or the CLL progresses. Now, when the CLL progresses, it's highly likely they're going to need to go straight onto the next treatment. So they won't get a treatment-free period. And for that reason, therefore, they also have a more prolonged exposure to the toxicity of the drug. So I think this treatment-free period and considering a patient's exposure to toxicity is an important part of the decision-making process. Now, I said that all of the treatment options are on the table for all patients, and I think that's true. And I said that no treatment choice is wrong. And we have this study, CLL 17, which was just presented at ASH just before Christmas in a plenary scientific session. And this was looking at this treatment paradigm of continuous BTKI versus fixed duration venetoclax-based treatment. And the study has led to a publication in the New England Journal of Medicine, specifically looking at fixed duration versus continuous treatment. And this is a large study, nearly 1,000 patients with previously untreated CLL, randomized between continuous ibrutinib compared to venetoclax and obinutuzumab or venetoclax ibrutinib. So they were specifically looking at a continuous treatment compared to two fixed duration treatments. Note, there's no chemotherapy arm in this trial. Some of the trials we look at as we go through this talk, you'll see that the previous comparator arms used to be chemotherapy or chemoimmunotherapy, but in this more recent study, chemotherapy is being removed altogether. This is the first treatment-naive study where it's just comparing these novel or targeted agents. And the hypothesis of this study, or its primary objective, was looking to see if they could demonstrate non-inferiority of the fixed duration regimens compared to a continuous BTKI monotherapy. And the study met its primary endpoint. It's met its primary objective. If you look at these progression-free survival curves and look at the numbers on the right, you can clearly see the curves are overlapping and the progression-free survival at 3 years is equivalent across the three treatment arms. So when they compared ibrutinib individually both to fixed duration IV or fixed duration VO, there was no statistical difference between the comparisons. This study also gives us some really useful information in terms of adverse events across these three sort of main treatment groups. Unsurprisingly, if you look at cardiac disorders, you can see that we see more in the way of cardiac disorders of AF compared to the venetoclax obinutuzumab arm. But you can see more neutropenia in the venetoclax obinutuzumab arm compared to VI or continuous ibrutinib. And in terms of infections, there was certainly more infections seen in the VO arm compared to the other compared to IV or continuous ibrutinib monotherapy. And when they tease this apart into the higher grade 3 to 5 infections, you can see there were clearly more serious infections in the VO arm. So this just reminds us that venetoclax and obinutuzumab does come with a treatment infection burden. So we're going to look through a little bit more data into the efficacy of these three main treatment options: fixed duration venetoclax obinutuzumab, fixed duration ibrutinib venetoclax, and continuous acalabrutinib and zanubrutinib. I've just mentioned here about fixed duration acalabrutinib and venetoclax in the Amplify study, but I'm not going to look at the data in that this evening, but maybe we could talk about it in the discussion section. I'm going to start with the data around the continuous BTKI monotherapies, and we're going to start with very, very basic sort of top-line headline data first. So first of all, I'm going to show you some data from the Sequoia study. This is a randomized study, nearly 500 patients, treatment-naive CLL. They excluded del-17p or p53 mutation patients, and they were randomized between zanubrutinib monotherapy indefinitely compared to 6 cycles of chemoimmunotherapy with bendamustine rituximab. And then I'm also going to show you a little bit of data from the Elevate-TN study. So this is the acalabrutinib study in treatment-naive patients. Here, these were treatment-naive patients who are a bit older, maybe with comorbidities, and patients were randomized between acalabrutinib compared to chlorambucil and obinutuzumab. There was also an arm where acalabrutinib was combined with obinutuzumab. So looking at the Sequoia study first at the top, this is the study with zanubrutinib compared to bendamustine rituximab, a clear progression-free survival benefit of zanubrutinib, and you can see this 75% progression-free survival at 5 years. Similarly, in the 6-year follow-up of the Elevate-TN study, looking at acalabrutinib monotherapy, this is this purpley line here, 62% progression-free survival at 6 years, and a clear benefit compared to the chemo arm. And so you can see this is why chemoimmunotherapy just doesn't come into it anymore in treatment-naive CLL. I've put a star here next to this sort of paler blue curve here. This is acalabrutinib combined with obinutuzumab combined with acalabrutinib, so AO rather than just A in this middle line that we're looking at here. So you can see there was an additional benefit when obinutuzumab was added to acalabrutinib. Currently, obinutuzumab in combination with acalabrutinib is licensed but is not funded within the UK. Looking at the fixed duration treatments, and again, we're just sticking with very simple headline data to start with. So this is a 6-year follow-up of the CLL 14 study. So these were previously untreated patients. Rather like the Elevate TNA acalabrutinib study, these are older or comorbid patients, and they're randomized between a year's worth of treatment with venetoclax obinutuzumab compared to a year's worth of treatment with chlorambucil obinutuzumab. And in the 6-year follow-up, again, a clear benefit of the Veno over the chemoimmunotherapy, and essentially a progression-free survival of over 6 years. Median progression-free survival. That study, the CLL 14 study, was in older or comorbid patients. This is the CLL 13 study. This is the 4-year follow-up from this German group study in younger fit patients. And you can see here at the 4-year follow-up time, there are 4 arms in this study. One of them is chemoimmunotherapy. Again, this is the blue line doing the worst out of all of them. This top one is a triplet. So here they have venetoclax obinutuzumab, but with ibrutinib added for venetoclax obinutuzumab. And you can see here 82% progression-free survival with Veno at 4 years in these younger, fitter patients. Interesting to notice here that this green arm here, the venetoclax rituximab, doesn't do as well as venetoclax obinutuzumab. So rituximab and obinutuzumab don't seem to be equal equivalents in treatment-naive CLL. What about fixed duration I plus V? So this is the GLOW study, the phase 3 randomized study in older patients with comorbidities, over 200 patients, and they're randomized to chlorambucil obinutuzumab or fixed duration 15 months of ibrutinib plus venetoclax. And again, IV is doing better than the chemoimmunotherapy arm, with over 60%, over 2/3 of patients remaining progression-free at 54 months follow-up. This is the Captivate phase 2 study. So this is a phase 2 study. There's no randomization, but this is just to show the same 15 months fixed duration of ibrutinib venetoclax in a younger, fitter cohort of patients compared to the GLOW study. Again, the same time point follow-up, 54 months, 70% progression-free survival. So they're all very good treatment options. You know, if you take very, very rough numbers, you're looking at least a half, if not something like 2/3. And in some of the studies, more like 3/4 of patients remaining progression-free around the 4, 5, 6 year mark after starting treatment. So the majority of patients are getting several years worth of progression-free survival with any of these treatment options. And this fits with the CLL 17 study telling us, I'm showing you the same slide I showed you before, that in the CLL 17 study, they demonstrated non-inferiority at this 3 and a bit year follow-up time point between the fixed duration regimens compared to continuous BTKI ibrutinib. But is there any guidance in specific patient groups? And here we're going to look at some of the genetic features that Dimar spoke to you about last week. So DEL17P or TP53 mutation, both conferring a poorer prognosis. These two often coexist. And also thinking about IGVH status, so unmutated IGHV tending to confer a poorer prognosis compared to mutated IGHV. So we're looking here again at the CLL 17 study, the non-inferiority study with the 3 groups, Veno, IV, and continuous ibrutinib. And we're looking here specifically in terms of DEL17P status or P53 status. And the first thing to say is that all of these patients in the setting of having a P53 mutation or DEL17P are doing much better with these 3 treatment options than they would be doing with either chemotherapy or chemoimmunotherapy. But you can see that there seems to be a trend towards worse outcomes for patients treated with one of these 2 fixed duration regimens, so either IV or VO, if they have a P53 deletion or mutation compared to if they're wild type. So you can see that in these bottom 2 groups, the green and the blue arms, compared to the patients having continuous ibrutinib, where there's much less difference between the outcomes in patients whether they have a P53 aberration or not. Similarly, we've seen this in the CLL 14 study, the fixed duration venetoclax obinutuzumab study. We can clearly see here that P53 mutation or deletion has a significantly adverse impact on patients' outcomes compared to those with P53 wild type when they're treated with venetoclax or obinutuzumab. I consciously point out here that I've always thought they clearly mislabeled these lines. I'm confident that I'm giving you this information the right way around. So the dotted line are the wild type patients, and the solid line are the patients with the P53 aberration. We've seen in previous studies, so this is the Elevate-TN study that I showed you earlier, the top headline data, where we had acalabrutinib, chemoimmunotherapy, or acalabrutinib with obinutuzumab. So if we focus on the two purple lines, and this is looking specifically at patients with or without a P53 aberration, you can see the two purple lines, which is the acalabrutinib monotherapy treated patients, are virtually overlapping. So it looks as if the P53 status doesn't seem to have as much adverse impact on outcome when you're treated with acalabrutinib monotherapy. So with a BTKI monotherapy compared to that fixed duration Ven-O. And similarly, and this is the biggest data set we have in treatment-naive P53 aberrant patients, is from the Sequoia study. There was a separate cohort with no randomization, just treated with zanubrutinib. These were patients with a P53 aberration, and they had over 100 patients in this arm. You can see this PFS of over 70% at 5 years. So in specific treatment groups, patients with a P53 mutation or del17P, I would tend to use continuous BTKI monotherapy, either zanubrutinib or acalabrutinib over fixed duration regimens. And personally, I would tend to prefer zanubrutinib, given that really good Sequoia data we have in the largest sort of patient group with P53 in this setting. What about IGHV? I think this is a bit more tricky. So we're looking at the CLL17 study again. So that non-inferiority study with the 3 arms of the novel agents. The first thing I want to point out here is if you look at the, sorry, I keep losing my cursor. I'm trying to find it again so I can point things out to you. So if we look here at Ven-O, one of the things that's really noticeable is how well the Ven-O patients are doing who have mutated IGHV status. So if we compare all the mutated IGHV groups across the 3 different treatment arms, the patients treated with Ven-O are doing especially well. Broadly, the unmutated patients over the 3 different treatment arms are doing fairly similarly, but we particularly pick out how well the mutated patients are doing with Ven-O. And we saw that in the CLL14 study. So when the Ven-O patients were stratified according to mutated or unmutated IGHV, you could see that the mutated patients did especially well with Ven-O. Now, that's not to say that the unmutated patients were doing especially badly, because this is long follow-up. This is out to 5-6 years. And around the 5-year mark, there's still 50% of patients progression-free. So even in the setting of unmutated IGHV with fixed duration Ven-O, your median PFS is still around the 5-year mark. With continuous BTKI monotherapy, so this is going back to the Sequoia study, where you could either have zanubrutinib monotherapy or be randomized to chemoimmunotherapy with bendamustine rituximab. So the zanubrutinib, we're focusing on these 2 top lines here, mutated and unmutated. So the curves don't seem to split as much as they did up here in this Ven-O when we're comparing mutated and unmutated. And the data does seem to suggest to us that when patients are treated with continuous BTKI monotherapy, the unmutated IGHV status doesn't seem to have as adverse an impact as it does in the setting of fixed duration Ven-O. And we've seen similar in the Elevate-TN study in patients treated with acalabrutinib. So any guidance in specific groups in regard to IGHV? Well, IGHV mutated, I would use fixed duration treatment where possible, because the patient will get a treatment-free period, avoid that indefinite exposure to toxicities, and we know that patients do especially well with venetoclax obinutuzumab. Unmutated IGHV, I think, is the hardest group of patients to counsel. That's my opinion. We know that the adverse impact of unmutated IGHV seems to be less with continuous BTKI. We know that from the Sequoia study with Zanu and the Elevate-TN study with acalabrutinib, compared to the adverse impact of unmutated IGHV when patients are treated with Ven-O, where unmutated IGHV does seem to have more of an adverse impact. But you have to balance that against the indefinite exposure to toxicity when a patient is given continuous BTKI. And bearing in mind that patients treated with fixed duration Ven-O who are unmutated don't do badly, they just don't do as well as the mutated IGHV counterparts. What about fixed duration IV in this setting? Well, I'll go back and show you the same 2 studies as before. So again, the GLOW study, treatment-naive, older or comorbid patients. So we're concentrating on these 2 sort of red and orangey lines here. So mutated and unmutated IGHV treated with fixed duration IV. And you can see that the PFS at 5 years of follow-up was 52% in the unmutated group, but clearly unmutated status having an impact on outcome compared to the mutated IGHV patients. Similarly, in the Captivate study, so the phase 2 study with no randomization, but in younger, fitter patients, and very similar numbers, maybe slightly better PFS of 55% at 5.5 years in the unmutated IGHV patients. So any guidance in specific groups? Well, unmutated IGHV, the same as with Ven-O, as with fixed duration IV, I think unmutated IGHV does seem to be having a negative impact on outcomes. Broadly, I think the PFS looks fairly similar at 5 years, whether you're using Ven-O or IV, fixed duration in these unmutated patients. I've grayed this out because I'm talking here about cross-trial comparisons when I say that the PFS with continuous BTK overall appears better than with fixed duration. But of course, the CLL 17 study, that 3-arm study, which is specifically comparing the 2 fixed duration with the continuous ibrutinib arm, is going to give us more data about this as time goes on. But I think when it comes to unmutated IGHV, it's a really careful discussion with patients about the 3 options, about the benefit of a treatment-free period versus a no treatment-free period in the exposure to toxicity, the potential differences in efficacy across these different treatment regimens. I think in terms of unmutated IGHV, the longer-term follow-up of the CLL study will be really interesting to compare continuous BTKI with fixed duration with a bit more follow-up, but also to look at fixed duration IV versus fixed duration venobinituzumab. And I think it's really important for us to understand the best way to treat these patients with the treatments we have currently available. And the CLL 17 study is going to give us some more information about that. I've not mentioned MRD-guided treatment at all, and I think that's very relevant in this patient group. MRD-guided treatment with IV was delivered in the FLAIR study. This is maybe something we can talk about in our Q&A session, but unfortunately we don't have access currently in the NHS to MRD-guided treatment. And now going to come on to patient factors that might sway you one way or another when you're thinking about your treatment choice. So I've actually highlighted in red here dual antiplatelets because I think that's one of the things that worries me the most, and I'm interested in our panel discussion what people think about this, but I think this is one of the settings where I would not use a BTKI. So if a patient needs to be on dual antiplatelets through some cardiology reason, I would tend not to use a BTKI because of worry about bleeding. And I guess often these things come down to personal experience, but that would be a patient group I'd be concerned about using a BTKI. An anticoagulant, I would not be especially concerned. So a patient on a DOAC who doesn't already have any sort of bleeding concerns in terms of bleeding phenotype, but an antiplatelet in combination with an anticoagulant for some cardiac indication, I might be a bit worried about that. In terms of cardiac history, any cardiac history would give me pause for thought about using IV fixed duration, and we'll look at a little bit about side effects in a moment to highlight why that is. A recent significant cardiac event, so for example, a patient who has had an MI in the last 12 months, that may well steer me away from BTKI monotherapy as well. But I think it's important to remember that when you're talking about a cardiac history, don't forget the potential risk of infusion-related reactions, which we're going to talk a little bit more about in a moment, and cardiac events when giving obinutuzumab in combination with venetoclax. So a cardiac history isn't just relevant when you're talking about patients who might receive a BTKI. I said about one of the things that might sway me is how quickly do we need a response? Typically, patients treated with Ven-O have quite a deep response quite rapidly. So if, for example, you had a patient with cytopenias needing important surgery and you need to get on with it, I would tend to use Ven-O compared to a BTKI-based treatment because Ven-O tends to have a more rapid and deep response. I've got a little bit of data just to highlight this. And this again is coming from the CLL 17 study comparing the Ven-O, IV and continuous ibrutinib. And the first thing to say is you can see, consistent with what they demonstrated, non-inferiority across the 3 groups, that the overall response rates are virtually the same across the 3 treatment arms. But just look in terms of the comparison of partial and complete response, we're seeing far more complete responses with the venetoclax-based arms compared to the continuous BTKI ibrutinib monotherapy arm. And this is very typical of BTKI monotherapy. It does not tend to establish such a deep remission, nor does it achieve such a rapid remission as when we use venetoclax-based treatments. And this is also highlighted in the MRD data from the same study. And Dimar talked to you a little bit about MRD last week. But you can see here when they were looking at patients with undetectable MRD to the power of 10 to the minus 4 in peripheral blood and bone marrow, they saw the highest rates of undetectable MRD in the Ven-O treated groups, then in IV, and no undetectable MRD in continuous ibrutinib. And that's very typical of what we see with continuous BTKI monotherapy. You don't get as deep a response, but as you've seen already from the progression-free survival curves I've shown you, you still get prolonged disease control. Factors that would not affect my choice. First thing just to mention is PPIs. This used to be an issue with acalabrutinib. You used to not be able to use acalabrutinib in a patient who was on a PPI, but due to a change in the formulation of acalabrutinib, that is no longer a problem. A patient in AF or a patient already on DOAC, that would not make me avoid a continuous BTKI. I would prescribe a continuous BTKI if I felt it was the right treatment after discussion with the patient, even if the patient had AF or was already on a DOAC. I think it's important you need to counsel the patient about bleeding risks and watch them carefully, but I don't think it's an absolute contraindication to using a BTKI. And I said before that a significant recent cardiac history, such as an MI or significant cardiac event in the last year, would probably cause me to avoid a BTKI, but well-controlled previous ischemic heart disease history would not automatically stop me from using a BTKI. I would, however, think very carefully about fixed duration IV in that setting, and I'd probably avoid it, and we'll speak about that a little bit more when we come on to the side effects in a moment. We know some data from additional analyses from the CLL14 studies, the venetoclax-obinutuzumab study, that bulky disease, bulky lymphadenopathy might be an adverse factor in terms of outcome when using venetoclax-obinutuzumab. To be honest, that very rarely plays into my decision-making. Again, that's something we can talk about in the Q&A session, whether anybody else is influenced by that when they're making a treatment choice, but I have to admit that it doesn't particularly affect me. So I'm just going to move on to the last bit of my talk now, which is specifically about how we manage the treatments. And this really is very practical. Side effects, logistics, things to remember when patients are having these treatments. So either of the fixed duration venetoclax-based treatments, you need to think about tumor lysis risk. And if you're using Veno, then you need to think about infusion-related reactions. Now, the logistics of treatment with fixed duration Veno, this is a 12-month treatment. Obinutuzumab starts first in the first cycle. This diagram here suggests that you give all of the 1,000 milligram first dose on day one, but I think most sites would use a test dose of just 100 milligrams on day one and then make up the rest of the dose with 900 milligrams the next day. The patient then comes back the next week for another 1,000 milligrams, the following week for another 1,000 milligrams. The following week, the venetoclax starts, and it then takes 5 weeks to get up to full dose venetoclax. So essentially, in those first 2 months, the patient has a lot of trips into hospital. Vastly, those will all occur just as a day patient on the outpatient unit, but I always warn patients that it's quite an undertaking just the first 2 months of treatment. After that, things calm down, and predominantly they're just attending once a month to the day unit. In terms of obinutuzumab, be wary of infusion-related reactions and warn patients about it. In the studies with venetoclax-obinutuzumab, nearly half of the patient had some kind of infusion-related reaction with obinutuzumab. This is much higher than the rate of rituximab, where it's more around about a third of patients. And nearly 10% of patients had a grade 3 or higher related reactions. So some of them would have needed hospitalization. The symptoms wouldn't necessarily have settled just with simple measures to try and settle the reaction down. So, 10% of patients having quite a significant infusion-related reaction. I always warn patients that the first 2 months of venetoclax-obinutuzumab treatment are a bit of a roller coaster. And I always say the best laid plans of mice and men often go wrong. Whatever we tell you, the dates we tell you when you're going to be coming in for your treatment, we might end up changing it because you have a big reaction and we can't treat you, or we have to admit you, or something needs to happen differently to the original plan. Any patients with a high white count, and this is completely my practice, a white count of over 50, I would say, or bulky lymph nodes or spleen, start very slow with that first test dose. And we've tended to put just that 100 milligrams and 100 mils and give 10 milligrams over an hour to start with, just to see how patients get on with it. We've often ended up admitting patients for that first day or first 2 days of treatment when they're having a significant reaction. But the thing is, if you go very slowly with the appropriate sort of preventative measures, paracetamol, hydrocortisone, Piriton, stopping the infusion when needed, letting everything settle down, then generally you can get the treatment in, but you need to go really slow. Looking at the logistics of treatment with fixed duration IV. So totally different setup here. Here, obviously, this is all oral. There's no infusions. Ibrutinib is given for 3 months on its own. So you get a 3-month ibrutinib lead-in, and then you add in the venetoclax, and you get 12 cycles of that. So it's 15 months of treatment altogether, whereas Veno is 12 months of treatment. You do need to make a formal TLS assessment prior to the venetoclax starting. In terms of venetoclax ramp-up, I think it's just really important to be familiar with TLS monitoring and how to manage it and assess for TLS risk. Whether you're using Veno or IV, it takes 5 weeks to get up to the full dose of venetoclax. You can see there the doses with the tablets, 20, 50, 100, 200, 400 over the course of the 5 weeks. With every week, there's a dose increase, and every weekly dose increase requires TLS mitigation strategies and monitoring. I've put a little NB at the bottom there. CLL venetoclax ramp-up is very different to AML venetoclax ramp-up, which happens over just a few days. Just a little bit of background, just thinking about tumor lysis, really just to remind you to sort of be up to date. And I've done a bit of reading about tumor lysis risk and management if you're starting somebody on venetoclax treatment for CLL. Specifically, the kind of numbers you need to know around the 5, 10, 25 sort of section. Is your lymphocyte count above or below 25? Are your lymph nodes bigger than 5 centimetres? Are they even bigger than 10 centimetres? Is the spleen bigger than 20 centimetres? And you can use that to classify low, medium and high risk. Essentially, if you've got lymph nodes more than 10 centimetres or a spleen more than 20 centimetres, you're automatically in the high risk section. All hospitals will manage TLS in terms of the mitigation strategies differently, so do what your local protocol is. But high-risk patients, I'd be going straight in with the rasburicase prior to the first venetoclax dose, and I'd be making the patient sit there and have IV fluids for 4 to 6 hours while they wait for their 6-hour blood test to be done. Low risk, I'd be happy with allopurinol and pushing oral fluids only. And for everyone at all dose titrations of venetoclax, it's crucial that you do bloods prior to the dose, bloods 6 hours after the dose, and bloods 24 hours after the first dose, but before the next day's dose is given. And the results of these bloods must be seen before the patient leaves the building or takes the next dose. If those are all okay, then you carry on with the rest of the week dose at that level until next week when the dose is going up again, and you do it all again. And again, just something very brief, I always keep 25% in my head in terms of biochemical TLS, because really if your potassium or phosphate are 25% or above from your baseline, 25% increase from the baseline, or calcium is 25% below from the baseline, then this is where you need to think there's some TLS going on here. And as one of my retired esteemed colleagues said, in terms of clinical TLS, patients die from the arrhythmias, not the renal failure. So that's the thing you're really trying to prevent here. In terms of logistics and side effects of treatment, apart from what we've said already with the infusion-related reactions and TLS, so venetoclax obinutuzumab, cytopenias can be an issue, particularly neutropenias. You can see nearly 2/3 of patients experience some kind of neutropenia with venetoclax obinutuzumab, and a quarter of them will be grade 3 or above. So, a fair whack of patients will get a decently low neutrophil count. Just press on. You don't have to stop the venetoclax, but support the patient with GCSF as needed. And every patient's different. Some might need GCSF once a week. Some might need it 3 times a week. It's a bit of trial and error. Also, we definitely see a bit of thrombocytopenia, and I find we see that particularly sort of in the early weeks of the obinutuzumab, and then sometimes it'll just resolve. And the CLL 17 study that I showed you earlier on has really reminded us of how infections, particularly those higher grade infections, can be an issue when patients are getting Ven-O treatment. So just be mindful of that. In terms of IV, similarly, around 1/3 of patients getting grade 3 neutropenia, not as many patients seeing the higher grade thrombocytopenia, but as with the BTKIs, and I'll show you a bit more in terms of side effects of the BTKIs specifically in the next in the next slide. But with fixed duration IV, we always just have to be mindful of cardiac events. And in the GLOW study, there were 4 cardiac deaths, bearing in mind these were an older comorbid group and the deaths occurred in patients with a cardiac history. But I think it's really important we are assessing patients carefully for fixed duration IV because of this cardiac risk. In terms of BTKI monotherapy, and I'm just showing you acalabrutinib data here. So this is from the ELEVATE-TN study. And I guess there's sort of 3 main things I draw patients' attention to when I'm talking about using BTKI is the cardiac events, and specifically AF or arrhythmias. You can see here with acalabrutinib, a rate of any grade AF around 9%, bleeding, and hypertension. And I think hypertension is a really important one not to forget. In terms of how we manage patients on BTKIs, there's been a really useful guideline printed a few years ago, which is a joint cardio-oncology guideline. It's over 100 pages long, so just search for the bit about BTKIs. But it gives a few sort of baseline suggestions in terms of assessments. Now, these predominantly are expert opinion rather than evidence-based, but it would suggest a baseline ECG for everybody before they start a BTKI, a baseline echo before starting a BTKI, and anybody considered high risk. And they would consider high risk to include just being male. So a man starting a BTKI should have a baseline echo. or if they're over the age of 65 years, or any of those sort of typical risk factors for heart disease, diabetes, hypertension, previous arrhythmias, and so on. Now, I think something that's really important for us to remind our patients and remind ourselves is about hypertension monitoring. This is an issue with BTKIs, and we must be telling our patients to get their blood pressure checked. And I admit, I used to tell my patients, make sure you get your blood pressure checked with your GP a couple of times a year. But actually, these guidelines would indicate we should be doing it much more frequently than that, actually asking patients to get their blood pressure checked every week for the first 3 months of treatment and then monthly thereafter. So I generally would recommend to patients, if they can, to get a blood pressure monitor to have at home. And then opportunistic checks for AF or arrhythmias. And I say it is opportunistic because many of the patients we are talking to on the phone, in phone clinics, rather than seeing them face to face. But if you are seeing these patients face to face, do a physical check of their pulse, see if there's any signs of AF. And also Fit watches or smart devices are very reliable, I'm told, by cardiologists in detecting AF and arrhythmias. So worth asking the patient about that if they wear a smart device like that. So I'm coming to the end of my talk now. I'm hoping I've covered my objectives as planned in terms of when to treatment options, how we might choose the treatment, and managing all the sort of logistical things. I think in terms of unanswered questions and ongoing studies in this treatment-naive setting, I think looking at venetoclax obinutuzumab versus IV or whichever BTKI venetoclax it is in the fixed duration setting is really important. And I look forward to seeing the longer-term follow-up of the CLL17 study. I think it's interesting to see whether all BTKIs and BCL2 inhibitors are created equal when we get more data about acalabrutinib or zanubrutinib replacing ibrutinib in fixed duration combination with venetoclax. There are certainly going to be new BCL2 inhibitors coming in the future. I don't think it will always just be venetoclax. And also the role of MRD-guided treatment. I've not really touched on that at all, but the role that MRD-guided treatment might have in the treatment-naive setting over fixed duration treatment. And I shall finish there. Thank you very much.
Ellen, thank you for that fantastic tour de force and your perfect timing. You landed us after a 40-minute talk. Let's get some Q&A going. We've already got a couple of questions. Now, first off, Helen, IWCLL guidelines to start treatment, I think we all agree with them still, but there's definitely a drift I find in practice with fatigue and generally feeling a bit rubbish. And it'll be great to get John's view. But if you're 77, you're feeling a bit rubbish, your lymphocyte count's 60, your hemoglobin might be 120, and you sat there thinking, well, what am I saving myself for? If I pop myself on some Acal or Ozana or something, I'll just simply feel better. And we know they probably will. So this old adage is a very British thing. We hold on and wait and wait. Do you find yourself slipping a bit, giving in, perhaps using treatment a bit earlier than you did when the days of chemotherapy were dominant?
I guess it is obviously different compared to when we were just using chemotherapy. And I think I guess it really comes down to who the patient is, as you say, in terms of their age, what we're trying to aim for. So if this is a 50-year-old, I would be trying to hold off treatment because I'm worried about how many years worth of treatment, how many years worth of disease control we've got to achieve. As you say, a patient in their 70s who's telling me they feel very fatigued and we've kind of, there's no other obvious medical reason for it. And they've got, they've clearly got active CLL in terms of, you said, a lymphocyte count of 60 or what have you, then I might consider using the treatment. But obviously counselling about the fact we're sticking you on a BTKI, we may well cause you more problems in terms of hypertension. And that's something certainly to be mindful of. I have to say I'm probably generally fairly resistant to starting treatment for just fatigue, if that's the only symptom.
You said patients are so different. 57-year-old patient of mine who was just very high stress job in the city, really pushing for a retirement bonus. He wanted to be there for 3 years on it. He didn't give a monkey's what happened when he was 60. Started treatment, but you sit there having the debate. John, let me get you on this one. So the patient and how much power they have over when you do or don't start treatment. Presumably you find variable reports from your members.
Yes, indeed, we do. And to quote Brian Kaufman, when you've met one CLL patient, you've met one CLL patient. And it is true. It can be driven by lifestyle so much, the fatigue question there. And it quite often depends on what that person's level of activity expectation was and how it's changing, which is why we're doing the survey at the moment with regard to trying to get a handle on fatigue so it's measurable, because it can be so subjective. And it's a dilemma for a clinician. we acknowledge it, but it's equally a dilemma for a patient to try and justify what they're saying and how they're feeling.
And the catches we've had, I said this, I think last year, one of the great was diabetes. A chap, we'd had all these debates and he was bringing up to start his treatment. And he came in, I said, oh, you're looking a bit brighter. He said, ever since my GP sorted out my diabetes, I'm feeling much better. I thought, oh, good. Diabetes, thyroid disease, general medical things. Now, let's get straight into, thanks, John, let's get straight into some nuts and bolts about treatment choices. And I can rotate around our consultant colleagues, because I came back from ASH with that big thing, fixed duration is everything. The joy of this meeting is we are not bound by pharma in any way. So if we want to talk about continuous therapies that we stop and turn into a fixed duration, if we want to talk about our views of licensed or unlicensed strategies, we can have those conversations now. I was struck by CLL 17. Of course, the death rate in the VO arm was double the death rate in ibrutinib. These are just throwing into issues of that trial. The follow-up is very short for a CLL trial. The drug ibrutinib, which, as you rightly highlighted, we just don't use very often, 16% atrial fibrillation in just 3 years of follow-up. Gosh, I think that was the worst AF rate we've seen. And it is an amazingly thought-provoking trial, abstract number one. But I think I did come back from ASH thinking I'm going to push more people into fixed duration therapy. Helen, at this broad overview, before we dive into molecular subgroups, did you come away from ASH with that similar viewpoint?
I think it's hard not to think about the different genetic subgroups, to be honest. I mean, I think it's a very nice, clear, they're progression-free, taking all comers, it's very clear. But the thing is that each patient is not an all-comer. You've got to think about their genetic other things that are going on. So I think because we know that there are, unmutated, P53, et cetera, it wouldn't make me think that fixed duration is always the answer in all patients.
Perhaps I came back with a slightly more, even slightly overriding genetic subgroups. Renata, you've been around, seen enough CLL data presented. Did you come out of the CLL 17 trial presentation thinking, wow?
Well, no, I was actually a bit disappointed because I thought, well, we'll see clear, because obviously the most interesting arm is ibrutinib and I plus V. We know that VO probably won't do very well with that group of patients. So as you said, we keep saying it's definitely too short. And already those graphs, what Helen showed, after 3 years, there's something is really interesting happening only a few months on. So yeah, I think this for high risk patients, unmutated, TP53 mutated, I think I would lean towards maintenance type of treatment, unless this is a young patient. And I think we did our guideline based on patient's choice. So does does CLL demands fixed maintenance? That's one part of decision, and second is the patient, because if like Helen was saying, there will be for some patients having a pill a day, it's fine because I take 3 other pills anyway, but for some other people having pill a day, it's a nightmare because it's kind of like almost virtual pharmacological prison. You have to remember that pill, and even if you set your alarm clock 5 minutes later, well, have I taken that pill? Alarm gone? Probably I have, or haven't. So being compliance is such an important factor. So if maintenance fits with a patient, fantastic. If fixed duration fits with a patient better, then I think that should override the genetic factors.
We can't help but be drawn into genetic factors. Nikesh, let me pick on you then. So the example I would give is we were quite aligned with what Renata was saying there about age. We did an audit of our practice in Cambridge last year and found that actually you're heavily influenced by age, actually, for the fixed duration versus continuous, which I wonder whether that was some of our slightly paternalistic view, thinking, well, you're older, continuous tablet, you'll be fine. Yet I was struck in my conversation separately with the German CLL group, unmutated patients 77, 78, which I think in our practice will be getting a BTK inhibitor, they're saying, well, look, give them fixed duration. Look, even unmutated, they can benefit from that. And so, Nikesh, let me get a Bristol-centric view. That unmutated molecular subgroup, How's it influencing your decision making in those 70-year-olds where there's so much potential choice?
So yeah, that unmutated group, especially if they're P53 wild type, it, like as Helen sort of mentioned, is that sort of very tricky group where they do all right most of the time. They're not quite as good as the better sort of mutated P53, and so I think there's it is just a big discussion about how they're getting on, what their cardiac risk factors. 70 is really difficult. So, and I guess the other thing just to think about with all the studies is, we talk about progression-free survival. That doesn't necessarily equate to time to next therapy. So you've always got to add in maybe another 2 or 3 years into that when you look at some of those curves. Sure, we'll have, on a trial, that they progress, they're finally their lymphocyte count has jumped up a little bit, whatever. But actually, some of these guys have got another time, another couple of years, 3 years even to sort of wait and watch and wait again as that sort of disease, as the crescendo again, if they're on a fixed duration therapy to needing more therapy. So I always think that bears into mind. But as you sort of, it's a sort of cop out here, but I really do think it is, from our patients, very patient-centric. I've got plenty of older patients who say, look, I just want to be done and dusted. They take the hit for that first 2 months of an OVEN strategy. The obinutuzumab gets in there. They've got that 8 weeks. And to be fair, we've been very lucky with our support strategy. So our advanced practitioners help manage the TLS monitoring, the VEN ramping. So having that being done, can we do that in the community? We used to have the company sending out nurses to do all as a part for a short while when the VEN. So I think they used to come out and do the bloods, and then we used to check them and then advise them. So a lot of those older patients, especially in more rural areas, we could do those blood tests remotely and then have a phone clinic and check on with them and do it in sort of real time. So that sort of mitigates some of the pain, logistically to get them in and out all the time. So I certainly, I really do like, the OVEN strategies in some of those older patients. But then, a lot of the time, they will just be happy with a pill. And I guess, second generation TKIs are a bit more, BTK inhibitors, are a bit more manageable perhaps than ibrutinib. You're going to see possibly a bit less of that atrial fibrillation, bleeding risk. And so a bit cleaner in that sense. But we do know with all these BTKs, there is a dropout rate, and I think only when I've had people stop those therapies after a long time, I had a few to come to me and say, oh yeah, I kind of forgot what it was to be normal without being on the BTK, but they sort of get used to it.
Grade 1.
Yeah. It just all
Nicholas, I'm going to keep it moving. So thank you very much. Nicholas, I'm going to put you on the spot, Nick, because you're our UK CLL chair, and we had our former UK trials lead presenting that amazing flare data and finishing his slide by basically telling us that if you weren't mutated IGHV or TP53, you obviously should be having an MRD-directed strategy. We have this challenge in the UK because so the flare strategy, you can treat, the major insurers are recognising that in the private clinics, like Acala plus obinutuzumab is used commonly in the private clinics, but we can't access that. So what do we say to a patient? And this happens in our clinics. They've done their research. They want MRD guided therapy. How are you addressing that in Nottingham?
Well, in the NHS, there isn't much we can do to work around the constraints of the direction of ibrutinib and venetoclax, unfortunately. But I do recognise that you had some more less limitations in the private practice. You could just choose to extend that treatment for slightly longer based on the flare data, and I think it's our job and our responsibility now as a group, as a research group, to sort of try to convince the regulators that is the best approach, and that definitely is giving patients remissions that are long enough that they could potentially need no more therapies in their lifetime, and therefore that the investment of some additional months of therapy on most of the patients is cost effective for the health system. So we got a big challenge. I think we've got the evidence, and I think the data from FLAIR will continue to evolve. We will get more molecular data, more MRD sort of data across the long-term follow-up of these patients, and hopefully have enough ammunition to convince the regulators. It is something I would love to be doing, to be honest. But at the moment, it is a bit difficult.
Thank you, Nick. And John, the patient view on this, not being able to access this remarkable therapy that we, the UK, have introduced to the world?
It's a dilemma, George. I really don't have an answer for that.
That's a problem we're all facing. Let me just sidetrack to TP53, Helen. I'll come back to you. I definitely take your point about the Sequoia trial. I think for balance, as I say, we don't have pharma sponsorship. If Stefan Stilgenbauer was here, he'd be reminding us that one of the problems with that Sequoia arm is that only 42% of the patients had an actual TP53 mutation. So there's a cut-off question about the fish, isn't there? So it's whether it was enriched for what we see as TP53 rather than completely as representative as some other trials. So that doesn't stop me from using zonarutidine and TP53s as well. But I think that challenging group of patients, which has historically been genomically unstable. But again, I've been at meetings saying, well, why are we denying them the opportunity of being off treatment for a while? But I suspect most of us are still just using fixed duration BTKI, aren't we?
I certainly do. I would certainly choose a continuous BTKI in a P53 aberrant patient. I would, if it was a younger patient, I would have the conversation with them about the treatment-free period and where we're ultimately aiming to get to. As in, we're going to have the opportunity to use the continuous BTKI further down the line, and how many years are we trying to achieve with your treatment altogether? But as a general rule, I would start with a continuous BTKI in that setting. And I think we've got limited data in terms of number of P53 patients treated in the IV trials, because obviously the P53 was excluded from GLOW, so we've not got that many number of patients treated in randomized study with P53.
I think that this cancer biology debate of two ends of the spectrum, where if you keep a clone smaller, then there is less turnover, less chance of that random event, a clone that's 100 cells rather than a billion cells. And so this argument goes, the more genomically unstable you are, the more important it is to maintain a continuous remission. And I guess unmutated CLL is sitting somewhere in the middle. Are you more likely to be better off 10 years down the line by keeping a clone flat or allowing it to regrow between bursts? And I've had that discussion with various molecular colleagues, and I think things like mantle cell lymphoma might get us a bit more nervous, because obviously the relapse molecular mechanisms tend to be a bit distinct from CLL, and CLL still is dominant on that BTK mutation evading. So i.e. Darwinian selection probably wins out a bit more than the clonal size expansion selection. Just philosophical debates. Renata, before I leave this, and we're going to have quick fires on the questions, don't worry, because we said we might overrun a bit. Renata, you've been around a long time. You must have a lot of patients in your clinic, first and second line BTK, that have stopped their treatment for whatever reason. And we've all got anecdotes of people who took the drug for 2 years, been in remission for 4 years, 5 years. But this frustration with the way NHS systems are set up is that we can't just stop them and actually convert a continuous BTK into a fixed duration therapy. And Nikesh's point exactly, that progression doesn't necessarily mean retreatment. And you can have somebody who can then have 2, 3, 4 years of therapy and reuse their BTKI. Do you feel frustrated by that in a day-to-day practice, or do you think, well, it's just an anecdotal observation and we are where we are?
Yeah, I mean, I had a patient like that, and I basically tried to navigate the system without upsetting my pharmacist. So I had somebody who had a TP53 mutation on ibrutinib. Ibrutinib caused dry mouth. She lost almost all her teeth. She was very unhappy with me because it cost her fortune to remove all those teeth. So, and at the time counts were fine. So I thought, fine, let's stop it then. So we stopped ibrutinib. Amazingly, HB was always sort of low. HB improved, and she had an amazing 2 years of treatment. And of course, as we know from E1912, its median is 2 years of treatment with those patients who stop ibrutinib. She slowly progressed, and I put her on second generation because I just called her that she was intolerant. And I had no problems getting her on a second generation, and she responded second time around again well.
I think you do make a very important point. If as a clinician you have a patient who's fed up with being on drug, label it as an intolerance in the NHS. If you're on ACAL, you can restart Zano, etc. And I think that's something we probably all feel comfortable with. And there was some data at ASH you might have seen with the French randomized trial, which elderly patients after 18 months on continuous ACAL are randomized to stopping or not. And the unmutated were relapsing much faster than the mutated, and I suspect the British trial that's addressing that after 3 years is perhaps a better time point, I guess, if we had choice, which is just a sort of final point of reflection. Now, I know I don't want to knock onto the next section. There are 5 questions in the Q&A. One is a complex one about a patient with a historical history of latent TB, TP53 mutation. Oh my goodness, I think discuss that one with your pharmacist. I'm sorry. Number 2, do you recommend reduced ACAL for patients on anticoagulation? So that's an interesting one. We'll just see if Helen has any points. Often, if there's no emergency, I start my anticoagulant at half dose for the first month to check, are you a bleedy patient? Can you be on 2.5 BD of apixaban for the first month? If no problems, put them up. As you know, there are data, people do use our BTKIs at half dose. They are flat dosed. Some people do fine on 1 tablet a day. Helen, any comments, quick fire on that one?
I do exactly what you do, George. I would tend to give full dose acalabrutinib. I'd give the lower dose of the DOAC. I'm always minded that that does potentially mean I'm prophylaxing my patient rather than therapeutically anticoagulating them. And exactly looking at the bleedy phenotype of the patient. If the patient was already very bleedy on their DOAC, then I'd probably say maybe we shouldn't be doing this.
And it is a debate. It's all of these, the HAS-bled versus your CHADS-FAS. And I was interested at a conference last year hearing a London cardiologist saying actually half-dose apixaban probably is protective against stroke in AF. And yet I'd been told by my Cambridge cardiologist needed full dose. So, and we're not cardiologists. Quick fire. Matthew, obinutuzumab is more effective than rituximab. Can we discuss again? More effective antibody. Actually, you know, Matthew, you are delving back into history because part of the criticism was the dose of the rituximab and the front loading, and was this a fair molecule by molecule comparison? And Nick's predecessor in Nottingham, Andrew McMillan, always hot under the collar about this point. I think history's moved on. At the end of the day, you're going to use obinutuzumab in the first line, and I guess rituximab in the second. Anonymous, I understand you cannot give BTKs temporarily to see whether it helps fatigue. Oh my God, this is speaking to my point. Wouldn't that be wonderful? Have 6 months of ACAL, see if you feel better. And then we can make a decision thereafter. You're just not allowed to do that because you use up that very important line of therapy. Once you've started with our rules, you are committed.
Helen, you mentioned about MI. So I've got actually a patient just like that. So you said you would not give BTKI somebody who had an MI within 12 months.
So I certainly wouldn't give IV. And then, because I had a similar young man, unmutated IGHV, he was exactly the person I would have given IV to, and he'd literally had a heart attack 8 months ago and had to be stented. So I was like, I'm not going to give you IV. If they've had their stenting and everything's sorted because they've had some angiography, there's a problem and it's been stented, I think that's a different matter. But I think if there's some other significant cardiac event, an arrhythmia or something, or some other thing, and maybe I'm concerned that it's secondary prevention and that the problem hasn't been sorted with a stent, for example, I'd be a bit worried about it.
There's a big risk, and allegedly high risk of bleeding with dual antiplatelet therapy as compared to coagulation with the BTKI. Yeah. So people who've had cardiac events very recently will be subjected to a period of dual antiplatelet therapy, which carries a bigger risk of bleeding, I think, with BTKI. So that's probably the reason why you should be careful, particularly close to the acute event.
I think I have a slight preference for Zanu if there's any history of cardiac electrical instability. But strangely enough, in my experience, Zanu seems to be a little bit more bleedy. So if we're taking a risk with other anticoagulants, it's funny how we all pick up these slight anecdotal feels. I'm not completely sure they're based on evidence. They're probably based on just, Mrs. Jones who came in last week.
And the beauty is we can swap it. If you've got some excessive adverse events, you can always swap to another BTKI. So luckily we can do that.
Helen, I'm going to thank you very much for that amazing talk.